Thank you, Dr. Stringer-Reeser, for your great presentation on risk factors. I am going to move forward with our meeting today and talk to you about diversity in cancer care and mainly focus on the different factors that can impact care in the early stage setting. Briefly, a broad introduction into breast cancer. As we know, breast cancer is still the most prevalent breast cancer diagnosed in women, and it is the second leading cause of breast cancer death still in our population. We know from the SEER data that was published in 2017 that around 260,000 women are diagnosed with breast cancer every year, out of which about 15% died from this disease, which is approximately about 40,000 women per year. When we look at the data in a little bit more detail and we look at it by subgroup and we divide the population on the different subtype of ethnicities that we have here in this country, we can see that the diagnosis of breast cancer is much more common in white women at 131 per 100,000 person in comparison to other type of races such as Black or Hispanic. The Hispanic being here reported at 99 per 100,000 and the American Indian at 79, so quite low in this population. Nonetheless, when we take a closer look and we look at the mortality of breast cancer in the population, we can see that things change significantly. Sorry about that. Let me go back to the right slide. There you go. So as we can see here, if we look at the mortality per population based on the race, you can see that white women, their mortality is reported to be 19.8 per 100,000, while for Black women, it is reported to be at 27.6. So certainly much higher than what we would expect. And so what I would like to talk in my brief presentation today is what are the causes of this gap. Over the past years, we have certainly made a significant impact on decreasing the mortality of our patients. Sorry, my slides keep skipping. And we have certainly decreased, if you look here at this graph, and here we have not only mortality for lung cancer, but also for breast cancer. So we're only gonna focus on the two lines that actually look at the breast cancer population. And what we can see here is that from 1975 until now, there has been a significant improvement in mortality, and that is due, of course, to changes in technology. Women have embraced even more screening, and there has been a much more, I think, more resources spent on making sure that the population is educated on early screening. But also it shows how much our changes in treatment have improved the survival of our patients. Nonetheless, despite all of that, we still see that for those women who are Black, even though their mortality has improved, it has not improved, which is this line here in purple, it has not improved as much as what you can see for women that are white in our population. And again, this is something that has been studied for several years, and we have looked at the different reasons and causes, and certainly socioeconomic causes are one of the main triggers, but there are other factors that we have to be aware and know about, and those are the ones that I am going to focus on today. So we are going to talk today a little bit about the patterns of care that can affect early diagnosis. We're also going to talk about how the biology of the tumor affects early diagnosis, and then lastly, but not least important, genetics. So we're going to start with patterns of care. So there was we know that there are different factors that can affect diagnosis at the early stage. There was a study done that it was an observational study, was published in JAMA in 2015, and this was done by Iqbal and its group. And basically what it was looking at is at the time of diagnosis, at how many patients were actually diagnosed with early stage breast cancer or a stage 1 breast cancer based on ethnicity. And what the study showed, which I found really interesting, is that patients that were white non-Hispanic, so white American, were diagnosed at a stage 1 at a much higher rate in comparison to Black Americans. They also look at other subgroups of patients. I don't know. Other subgroup of patients, and we could see that even when you compare it with Japanese women, Chinese women, or other ethnicities, where the rate was 43%, still the white non-Hispanic women were still diagnosed at a much higher rate. And when we look a little bit more in detail at why this could be, one of the things that it was noted is the quality of the screening. So as we all know, mammogram is still our standard of care for screening. And thankfully, there has been several advances in this field. And now we do have the digital mammogram or tomosynthesis or 3D mammogram. And we have made, as I said before, quite a big amount of advances in making sure that patients are aware that this is available to them and reaching out to all communities to make sure that they know the importance of a screening and how this can impact their care. So despite the significant improvement in access to screening, we still are having delay in diagnosis that are thought to be secondary to the mammogram. And it's mainly related to the mammogram quality. And so there was a study done that was published in 2013, and this was done actually by a group in Chicago that looked at around 268 women. And what they did is that they got a breast radiologist that was, of course, dedicated just to look at breast mammograms. And they gave him blinded mammograms that we knew that trigger further workup. And they also gave him access to at least 2 years of mammograms prior of each of these 268 women. And the interesting part that they note is that not only the quality of the imaging, but also the reading of the imaging impact the early diagnosis. So they stratify this woman not only by income, but they also stratify the woman by where they got their mammogram. As you can see here, some of the women went to public or private mammogram sites. Also, you can see here that some women actually got their mammogram read by a breast specialist in comparison to women that had access to their radiology side, where the radiologist reading mammograms was not a breast specialist or not a dedicated breast radiologist. And they know that there was a significant difference in the time that the abnormality was caught. So for those women that had access to a center where there was a specialized breast radiologist, the chances of the quality of the imaging and the reading was about 74% in comparison to the other sites, which was about 40%. And the same thing happened when the woman went into a large academic center or a large hospital that had an academic view in comparison to the woman that went to a small private imaging center. When they look at other factors such as income, certainly those women that had higher income had higher chance to have better quality imaging, and that of course meant early diagnosis. They also look at ethnicity, and again, you can see a little bit better improvement or better imaging done on women that were non-Hispanic white, as they categorize in comparison to other ethnicities. So certainly we can take from here that, that we're still, even though we do have access to imaging, the quality of the imaging and the quality of the reading is quite important when we're trying to improve in early diagnosis. There was a quality a Standard Act that was passed in 1992, and the Quality Act was to improve precisely these discrepancies in between one side and another when the women are going to access care. The problem with the act is that it's very flexible in the sense that they only go and actually go into each of these imaging sites every 3 years, and the imaging site actually has the capacity to before the inspector comes, they actually are able to choose and pick those images that the inspector or the person that is reviewing the quality of the site is going to review. So of course that can have significant bias and can make very difficult to improve quality out there in the community. Another aspect that was noted in regards to diagnosis and early screening, and that was looked into, was the timing for follow-up. And what this group actually meant by timing to follow up for imaging was the time when the woman came and had their mammogram, and how long did it take for that site or radiology center or physician to be able to contact the woman and be able to bring her back either for biopsy, further imaging, and further workup, and how much that in itself could delay care in the future. And so this study was a study that was done actually at NYU, and they look at around 6,000 women. And what they note, again, as you can see here in the table, is that for women that were white, the follow-up time was about 14 days, while for women of other ethnicities, such as Hispanic or African American, it took about a week more to be able to get them to follow up. So certainly, even though it's not a big amount of time, 7 days, it's still 7 days that is delaying the diagnosis of this patient. So it's still significant where we're talking about a process that will require and entail a lot of people being involved, such as the oncologist, the surgeon. So certainly any type of delay, it's important. When they look more in detail to try to understand why these delays happen, what they noted is that it was most likely related to, again, socioeconomical factors, because some of these patients that they were not able to bring for follow-up for a biopsy or extra imaging, the barrier was basically because they couldn't access the hospital, either because they didn't have the means, they didn't have transportation, they couldn't take the time off. So again, the delay in diagnosis sometimes could be the lack of an adequate and quality imaging center, but also it could be compounded with other socioeconomical reasons. If we look at the biology of the breast cancer, which I find that is something that we don't think about too much when we're talking about factors that impact early diagnosis, and when we're talking about diversity. When we look at the biology of breast cancer, and as we all know, this is a very heterogeneous disease. Breast cancer is not just one type of breast cancer. We have different types. The most common one, as most of you know, is hormone receptor positive breast cancer, We also have our triple negatives, and then we have the HER2 positives. And for those that, of course, are triple negative breast cancers, which are 13% of the breast cancers that are diagnosed, we know that those patients tend to have a much more aggressive type of disease that tends to grow faster. And so when we're thinking about biology, we want to try to understand how biology impacts the diagnosis. So what this group did in California was look at about 40,000 women that were diagnosed with breast cancer from 2006 to 2007. So for a full year, they look at all the women that were diagnosed, and then they look at the different types of breast cancer that were diagnosed and how these were divided in between the different ethnic groups. And the interesting factor that they noticed that for Black women, triple negative breast cancer was much more prominent in the diagnosis of triple negative breast cancer was more prominent in comparison to the incidence of triple negative in white women or even in Hispanic women. As you can see here, is only 1 in comparison to African Americans, which is much higher at almost twice the risk of developing this disease. On the other hand, you can also see that in general, all women independently of ethnicity are at high risk of developing what we call luminal breast cancer or hormone receptor positive breast cancer, which tends to have a much more positive or better prognosis. So in general, the lifetime risk of this type of breast cancer for all ethnicities is high, but in white women, it is significantly higher. While the one that has a worse prognosis, as I said before, it has the lifetime risk for this woman, for Black women, is much higher. So again, this can impact, certainly this is a way on how biology can impact early diagnosis, because if you have a tumor that tends to proliferate faster, it would be more difficult to catch it at an early stage. And again, this is from the same group of physicians, sorry, the same cohort of patients. And it's a graph way of showing what I just said, which is the significant incidence of hormone receptor positive breast cancer in white women in comparison to the other ethnical groups. The hormone receptor positive is the one in blue. And then we can see also here that for women that are white, and in general, all women, the diagnosis of hormone receptor positive tends to peak, or we have the highest risk of developing this type of breast tumor at around our 70s, when we are in our 70s. While for the other types of breast cancer, such as triple negative and HER2, it seems that if we see here, there is a little bit of a peak around their 60s, so a little bit earlier in the Black population in comparison to the other populations. So understanding also this risk can also allow us to make recommendations more so as primary care physicians or caregivers of how aggressive we want to be for with our screening on our patients. We know that the task force has made the recommendation after a certain age to only do mammograms every 2 years, and then after a certain age stop doing a screening. But it is important to see how, you know, the different risk of the different types of breast cancer is seen within the different ethnic groups. We also I also took a look at this trial here. And again, this is the same trial that I showed you before from JAMA 2015. And what was interesting is that they not only look at how often women were diagnosed with early stage breast cancer based on their ethnicity, but they also look at the impact of diagnosing a woman with a small tumor. And as you can see here, so a small tumor, they actually define a small tumor as a tumor of less than 2 centimeters. And they look at how many of these women that had a small tumor of less than 2 centimeters had already lymph node involvement based on their ethnicity. So again, trying to understand biology of the tumor. You would assume that because a woman has a small tumor, there is no chance that the tumor has had time to go to the lymph nodes. But as you see here, women with small tumors that were Black were more likely, or Hispanic were more likely to have already lymph node involvement in comparison to non-Hispanic white. And so again, we're going into the same conversation of seeing how the biology of the tumor, if we're thinking about triple negative breast cancer being more often seen in Black women, even though the tumor being small, how that can affect the stage at the time of diagnosis. And again, it shows what we already know, that triple negative, is a big factor that impacts early diagnosis in Black women. So again, looking at the biology, understanding the impact of biology in early diagnosis and how we should be thinking about the different women and the importance of screening. They also look at the survival of these patients based on whether or not they were estrogen receptor negative or positive, and based on ethnicity. And we see again a significant difference in survival and risk of death based again on race, as well as socioeconomical status. So here we can see how the death rate was much higher among Black women in comparison to other ethnicities. So for example, if we were to compare to Japanese women, and again, the impact of socioeconomical status, here we see that women that have an income of more than 75,000 was much better in comparison to women with a lower income. And again, this is mainly, they were looking mainly at small tumors, tumors of less than 2 centimeters. So we see how the biology of tumor is important. Last but not least, we have genetics, which again, I think it's a field that is evolving, and we've been very much interested in the growth of this field, because we know that germline genetic mutations can have a significant impact on the care of our patients. The most common type of gene that we diagnose is the BRCA gene, and this has been the one that actually we've known for the longest time, but there are other genetic mutations that we're looking into that also increase the risk of women to develop breast cancer. We know that there are subpopulation of women, such as women from the Bahamas, that have a higher risk of having this mutation. So in general, there are 2 different types of BRCA gene mutations, the BRCA1 mutation, the BRCA2 mutation. And when you are a carrier of the BRCA1 mutation, we know that your risk can go all the way up to 65% of developing breast cancer. And so this here is to know the risk of a woman of developing breast cancer when the person does not have a mutation and is not a carrier of a germline mutation. So you can see that a woman in this case only has a lifetime risk of developing breast cancer of 12% in comparison to those that are carriers. And then we have the women that are BRCA2 carriers, and their risk is about 45%. So as the field of genetics has grown and we have a better understanding, and we understand that this gene not only is seen in certain populations, but the view is much broader, that we can find it in Hispanic women, in Black African-American women, as well as Asian, although not that common. That also has had an impact on how we screen our patients and how we bring them to early diagnosis. So here is a table that, again, what is trying to show, or what I was trying to show you here is, again, the probability of being a carrier of one of these BRCA mutations based on ethnicity. And so we now know, in comparison to years back, maybe 10 years back, when we just started talking about genetic testing, that the probability of being a mutation of a BRCA gene is almost equal in between Black and white women. But when we look in more detail and we look at a younger population of women less than 35 years of age, we know that numbers are different in that case, and that younger women that are African American have a much higher chance of being diagnosed with a BRCA mutation in comparison to white women, and the difference is quite significant. Nonetheless, despite the fact that these numbers are there and we are aware of these differences, genetic testing is still a big issue in the community, because it's not being done. Women that are at high risk for being carriers are not being identified. And there have been several studies that have been done that have looked at the reasons why this genetic testing is not being done. And for the most part, one of the reasons, or one of the barriers, has noted to be education. We need to educate more our physicians, but we also need to educate more our patients to understand what the purpose of genetic testing is and what it means to them, as well as what it means to their family. A lot of physicians are still using outdated guidelines in which patient fits or meets criteria for genetic testing. And these guidelines have been updated several times over the past 10 years or more. And it keeps including much younger patients, as well as it has a much broader inclusion criteria. So certainly educating our physicians in the community is extremely important. It is one of the reasons why testing is lacking in other ethnicities, in minorities in this country. And it is important to be able to reach these patients for many reasons. One, because if we're able to diagnose a woman with a BRCA gene mutation at an early stage where they are not yet diagnosed with breast cancer, there are preventive measures that we can take, such as surgery and medication that we can give the patient to try to decrease the risk of developing cancer. So, and this can have an impact not only for that woman, but also their family members. So this is actually a very powerful tool, but the lack of testing certainly is one of the things that, in my eyes, has decreased the chances of early diagnosis and hopefully prevention. So this is something that for me is very important, and I'm a huge advocate of trying to educate the community on the importance of genetic testing. A while back, the access to genetic testing was very limited. And mainly it was because insurances were not covering genetic testing, but nowadays all those barriers have changed because there are many companies doing genetic testing that have good quality testing. The price has gone down, and again, the NCCN guidelines, which are the guidelines that we use in cancer care, have embraced broadly genetic testing, and that has, of course, made us have a very strong case in front of insurance companies, so our patients are not denied So it doesn't matter what insurance the person have, it's still genetic testing as long as the patient meets the criteria. I think that is something that most of the women are able to access. So, so in brief and in general, I think what I wanted to show you with this presentation is that the main delays in early stage diagnosis are not only socioeconomical, although that is a very big factor, but also it is understanding that the reason is multifactorial. We are a diverse population, and you know, we are made of many different ethnicities, and we behave in a different way biologically, as I have shown, as well as, you know, we have our own innate risks because of our genes. And so understanding that those factors are there as physicians can make us be a little bit more aggressive in screening in certain populations and less adamant in others that we think can, the regular screening is optimal for them. So with that, I think I'm going to end my presentation. I want to thank you all for being here. And if you have any questions, please go ahead.